agents. So our course objectives for today are to define a non-depolarizing neuromuscular blocking agent, or NMB, identify situations when NRBs are needed, develop a concurrent medication plan when we have an NMB, and evaluate NMB use in a case study. So what do neuromuscular blocking agents do? They are drugs that block the cholinergic transmission between the motor nerve endings at the nicotinic receptors on the skeletal muscles. So we'll focus on the antagonists, or the non-depolarizing blocking at the ends of the neuromuscular junction. So in our hospital we usually use Nimbex or Vecuronium, but Mivacurium, Pancuronium, or Rocuronium are also used if you get a patient directly up from the OR and they say that they gave the patient rock before they came up. They're referring to Rocuronium. So why are they used? They're used for rapid sequence intubation in our hospital. When we call an airway emergency, they will have these meds ready. During surgery, pre-surgery, when they're about to intubate, they use this to relax the muscles so that they can intubate the patient. And in the ICU, when we have a mechanically ventilated, critically ill patient that is in ARDS or has a severe lung injury, or they're trying to monitor the ICP so they don't want them to rise, they will use a neuromuscular blockade so that the patient does not have to exert any energy. So what's the key word that we're looking for here? Our key word here is that the patient is intubated. Your patient must be intubated for this med to be used. So what's the mechanism of action for these neuromuscular blocking agents? They are competing with acetylcholine at these nicotinic receptors on the motor end plate. So they don't stimulate it. What they're doing is they're preventing depolarization, so they're inhibiting muscle contraction. If there's no depolarization, then the muscles cannot contract. So different muscles will have different sensitivities to the medication. The small, rapidly contracting muscles in the face and the eye are the first ones that will be affected. And then it will be the hands and the limbs, the neck and the trunk, and finally into your intercostals and diaphragm. So notice these are all skeletal muscle. We haven't mentioned anything about cognition because neuromuscular blockade does not affect cognition. We'll talk about that later. So to monitor the depth of the neuromuscular blockade, a peripheral nerve stimulator, this looks similar to this, is used to measure the train of 4. So in most cases the electrodes are placed on the face or on the ulnar nerves, and then 4 supramaximal electrical impulses are sent to stimulate the nerve. So it's essentially a small shock that's sent to the nerve to see how many twitches. Now you and I, who are awake and alert, will get 4 out of 4 twitches. But someone who's using this medication, depending on how it's being titrated, will have anywhere from 0 to 4. We don't want them to have 4. We don't want them to breathe because the vent will do that. So we aim for usually 1 to 2 twitches. If they get to 0 twitches, then they might be over paralyzed. So we need to speak to the physician how strong that they want it. But we use that to control their muscle. So let's think about what we just talked about in the ICU. So we use these neuromuscular blocking agents. They're blocking the acetylcholine to block the muscle contraction. And then we're also using additional monitoring to monitor the patient's train of 4 and the depth of this blockade. So these patients are in severe lung injury. They have ARDS. We want those lungs to rest, right? But we don't want the patient to have to feel or remember them not being able to control their muscles. So what's important for us to do is to sedate them and provide adequate analgesia. So optimal clinical practice suggests that analgesics and sedatives drugs should be used before and during neuromuscular blockade with the goal of achieving deep sedation. So there was a study done among 5 university hospitals, the Mayo Clinic, Cleveland Clinic, New York Presbyterian, Ohio State, and Vanderbilt, and they tested the nurses on their understanding of neuromuscular blockade. 92% of them were able to identify that neuromuscular blockade did not have analgesic properties, and 82% were able to identify that there were no sedative properties with neuromuscular blockade. So our goal is to emphasize that our nurses know that neuromuscular blockade do not have sedative or analgesic properties, and we must have concurrent orders for us to administer this medication while they're intubated. So there have been errors when neuromuscular blocking agents are used. They are a high alert medication because there is a well-documented cases that have errors because people are administering the wrong drug. They don't know that they're using a paralytic, and they give it, and that's when the adverse reaction happens. So in the literature, there have been several documented examples. These are some of them. In the emergency department, in one of these examples, pancuronium and influenza were next to each other, and these are what the vials look like. So the nurse gave pancuronium IM, thinking it was influenza IM. So these patients went into respiratory distress and were monitored. Luckily, were monitored, and they were able to catch it and reverse it. But there was another case that in the literature stated that the patient was on vecuronium and potassium chloride, but the patient got extubated, but the medications were left at the bedside. So when the nurse was going to hang the next potassium chloride, what she actually hung was vecuronium. So the patient went to respiratory distress, had to get reintubated, and stayed reintubated for a while before they could reverse them and bring them back. So there was another example given that the physician ordered the vecuronium on a different patient with the same last name. The patient was in fact in the ICU, but the patient that he was ordering was on the med-surg floor. So pharmacy reconstituted the medication, the nurse hung the medication, and because of knowledge deficit, didn't know that it was a paralytic. So again, the patient went to respiratory distress, got no control of their muscles, and coded, and then had to be intubated and reversed again. Okay, so these errors do happen because people are administering this medication without knowing what it does. Does anybody know who this person is? Okay, her name is Rodonda Vaught. She is the Vanderbilt nurse that gave vecuronium, a paralytic, instead of Versed, a sedative. Her patient needed to do an imaging scan and was very anxious about it, so the physician ordered Versed, but when she went to the Pyxis, she typed in VE, and she couldn't find the Versed, and got the first medication that came up with the VE, which was vecuronium. She gave the patient the vecuronium and sent the patient to the scan, and another hospital personnel found the patient to not be breathing and coded the patient, sent the patient to ICU, where she died the next day. So now this nurse is charged with reckless homicide. So we need to know that we are administering these medications and know what they are doing before we give them. Okay. We had, there is a case study that we had with a 38-year-old male trauma patient that we received back from the OR straight to the unit. The patient was on mechanical ventilation with vecuronium, Ativan, and Dilaudid drips infusing. At 2200, the patient started to get hypotensive. Blood pressure was in the 80s with MAP in the 60s. So the Ativan and Dilaudid drips were stopped. And then the Biz and the train of 4 were continuing to be monitored. And the vecuronium was infusing at 0.25 mics per kilo per minute. So if we think about what we were just talking about, what would cause us to think there was something wrong in this situation? The Ativan and Dilaudid drips were off, so the patient had no sedation and no analgesia, yet the vecuronium was still on. So luckily the patient was intubated, so he still had a patent airway, and he eventually got extubated and discharged and did very well. But during that brief moment of time, what was happening to the patient? they were blocked, their muscles were blocked, and they might have been able to hear or experience that post-op recovery. Okay. So what do neuromuscular blocking agents do? You know, they block the acetylcholine, so they inhibit the muscles from contracting. Now, when should we anticipate using that? Anytime during intubation for rapid sequence intubation, during airway emergencies, pre-op before they go to surgery, and in the ICU when we want to make sure that we rest their muscles, we rest those lungs, and let the ventilator do the work. And do neuromuscular blocking agents have analgesic or sedative properties? No, they do not. We need to ensure that the patient has an analgesic and a sedative concurrently ordered with this neuromuscular blocking agent. Any questions? Great, thank you.